My name's Steve Gabardi. As Jamil had mentioned, I'm the transplant pharmacist in abdominal organ transplant at Brigham and Women's. I have no disclosures to make. I will be talking off-label, as most meds are in transplant. My objectives, we're going to talk about the drugs. We're going to go into mechanisms of action. Dr. Ozzie already touched on most. We're going to go into adverse events. We're going to go into drug interactions. We're going to try to differentiate one drug from the next within these different classes. And we'll finish with management strategies for cellular and antibody-mediated rejection. Pharmacology discussions tend not to lend themselves well to case discussions, especially when we're not going through each agent and trying to set up an established protocol. But just to set up the discussion, I have two cases. An MG is a young 33-year-old male, IgA nephropathy, waiting for a preemptive transplant. His mom has been cleared for donation, so one haplotype match. No transfusions or prior transplants, never been on immunosuppression, no malignancy, and no severe infections. He has no PRA. This was a transplant that we did about 3 or 4 months ago. For what we would consider our typical Thursday morning living donor transplant. Because we're going to start off with induction, potential recommendations for induction. This is where you can't look at one set of immunosuppression in a silo, because oftentimes maintenance immunosuppression plans will dictate how you immunosuppress with induction therapy. So this is a patient that's low risk. Living donor transplant, you could consider using an interleukin-2 receptor antagonist. You could also consider using depletional therapy, especially if you want to limit corticosteroids or limit calcineurin inhibitor exposure. So in a silo, choosing specific induction, you could choose any induction agent you'd like. For this patient, it all depends on what your plan is for maintenance therapy. But to give a bit of a contrast, a transplant that we did the same week was a 75-year-old female who had end-stage renal disease secondary to diabetes, has been on hemodialysis, is receiving a deceased donor transplant with a KDPI of 85%, already has 15 hours of cold ischemia by the time the patient presents to the emergency department, does have some immunologic risk in the fact that she's been pregnant, but has no previous immunosuppression, cancers, or severe infections. This patient also has no PRA class 1 or class 2. So a little bit different from what our first patient presented as, but again, depending on what your maintenance therapy is, you could use induction from a whole host of different agents. Now, obviously, your host in this specific example is less likely to reject as an older recipient, but with a high KDPI score and potentially or more likely an older donor, you may increase that risk for rejection. And as Dr. Ozzie had mentioned, the cold ischemic time getting longer also increases that risk. So even though you have an older potential recipient, you may consider this patient to get a more depletional therapy in terms of induction. But again, your choice of induction really depends on what your choice of maintenance therapy is. We'll get back to these cases, but we're going to start with our basic principles of immunosuppression. And I realize that this study is very old. It was published in 1999, but this is the study that kind of made transplanters really start to focus on acute cellular rejection, and this is what brought the onslaught of induction therapy in the US. And this was by Humar and colleagues, looked at a single center outcomes from 1984 to 1998 using archaic immunosuppression with cyclosporin, prednisone, azathioprine, no induction, and basically brought their patient population into two groups. They looked at their living donors and they looked at their deceased donors. And they found that if you had rejection in the first 12 months, if you had acute cellular rejection in the first 12 months, regardless of whether you had a living donor or deceased donor, you had poor long-term outcomes. And what you saw after this publication was a huge uptick in induction therapy use in the U.S. So now, across the U.S., induction therapy is much more common than no induction therapy, and depletional therapy is much more common than in any part outside of the U.S. And this was the study that basically forced a lot of centers to start focusing on lowering acute cellular rejection to potentially improve long-term outcomes. Now, what we've seen since this study was published was a reduction in acute cellular rejection rates from 35 to 40% down to about 10%. Unfortunately, we did not see a commensurate increase in long-term survival. And that's likely secondary to the impact that antibodies play that weren't recognized in 1999, but also the impact that our toxic calcineurin inhibitors play on long-term graft function. The second principle is that, of course, all patients aren't created equal. You'll immunosuppress folks differently depending on their risk. And if you had an identical twin or somebody that is receiving a kidney from the same person that donated them bone marrow previously, you're obviously going to err on the side of little or no immunosuppression versus your patient that are highly sensitized or even your high KDPI score patients. They're not high immunologic risk, but tend to get more immunosuppression given that their kidney is substandard to begin with. But obviously realizing that you may use the same drugs for the same patients across the board, I think we rarely change our maintenance immunosuppression de novo, but realizing that we'll use them differently in different patient populations. So we'll quickly go through our induction agents, our maintenance agents, and our anti-rejection meds. I'm going to leave out the drugs used in special circumstances like using leflunomide and BK patients and such, but we will go through the three general classes of immunosuppression. I know that Dr. Ozzie showed something similar, but certainly we have meds that work all across the spectrum of the immunologic response. We have several drugs that work on cell surface markers, our antibodies like our polyclonal antibody ATG, our anti-proliferative belatacept and Basiliximab, and our depletional therapy Alemtuzumab. And then, of course, intracellular, we have our drugs that prevent the formation of interleukin-2, including our calcineurin inhibitors and our corticosteroids, and our drugs that prevent response to interleukin-2, our mTOR inhibitors and our anti-proliferatives. And we'll get into each. But we'll start with induction. And of course, since that HUMAR study came out, the major goal of induction was to lower acute cellular rejection, and it's done just that. Our rejection rates are the lowest they've ever been. But one of the secondary benefits of giving induction therapy is that it allows us to manipulate our maintenance immunosuppression. So without induction, we can't do an early steroid withdrawal regimen. Without induction therapy, I can't delay the onset of calcineurin inhibitors until I get some degree of renal function following the transplant. So induction therapy has allowed us to manipulate our maintenance immunosuppressive regimens to a point where we're able to do withdrawal or sometimes avoidance regimens for some of these medications. We can talk about these induction agents as monoclonal or polyclonal antibodies, or monoclonal or Basiliximab and Alemtuzumab. Of course, our older OKT3 and Daclizumab are no longer available in the US. They've been off the market for about 8 years now. And then we have our polyclonal antibodies, our horse ATG and our rabbit ATG, thymoglobulin. But we don't generally talk about them as monoclonal or polyclonal. We talk about them as depleting or non-depleting agents. So our non-depleting agent is our Basiliximab, while our depleting proteins are ATG, both the rabbit and the horse, and Alemtuzumab. So looking specifically at Basiliximab, it is a mouse monoclonal antibody that was humanized, and that was Daclizumab. Since the onset of Daclizumab, it was found to have low binding affinity. So Basiliximab was made with a larger percentage of mouse protein. It's about a 75%, 80% human protein that binds to the alpha subunit of the interleukin-2 receptor. So here this antibody binds to and works as a receptor antagonist on the interleukin-2 receptor, so it prevents clonal expansion. The typical dosing is split into 2 doses. There's a dose given at the time of transplant and a dose on postoperative day 4. Why the manufacturer decided to do this, I'm not quite sure. But truly, you need to get 40 milligrams into your patient to saturate the interleukin-2 receptor. So all the pharmacodynamic data shows you could give it even as a single dose, but you need to get 40 milligrams into a patient within 7 days in order to saturate the interleukin-2 receptor. And that saturation will stay for up to about 10 weeks following the transplant. So you give a few doses, and you're getting approximately 10 weeks worth of immunosuppression out of this induction agent. There's no drug-drug interactions, so it tends to be an easy medication to use. And of course, if you look this drug up in any tertiary textbook, you'll find that there are tons and tons of side effects. But when this drug was studied, there was no such thing as induction, and it was studied versus normal saline in all patients that were getting cyclosporin, mycophenolate, and prednisone. And there was found to be no statistical difference in terms of adverse events, including infection or malignancy. So it tends to be considered a very, very safe induction agent because it does not increase risk for adverse events, especially immune-related adverse events. To switch gears with our ATG preparations, they're basically formed by immunizing an animal with a purified or immunizing an animal with human lymphocytes and then drawing off those anti-human antibodies. So you get this cytotoxic array of multiple different antibodies in your one lyophilized preparation of ATG. And the basic mechanism of action is that these antibodies bind to their receptors, recruit human complement, and cause depletion through a complement-mediated mechanism. I had mentioned that IL-2 receptor antagonists give you about 10 weeks worth of immunosuppression. A standard dose, a 2 to 5 day dosing of rabbit ATG generally gives you about 3 months worth of immunosuppression. I'm going to show you some clinical data that compares the horse to the rabbit, and believe it or not, one is better than the other. The rabbit ATG is much more efficacious, and it got folks asking the question, why? They're basically the same drug, just from different animals, but when they did mechanistic studies beyond the depletional activity, you got a few significant differences in terms of mechanisms of action. When folks reconstituted their immune system about 3 months after getting rabbit ATG, they reconstituted it with more suppressor T cells than they had previously, and that wasn't the case with horse ATG. There was also B-cell apoptosis with the rabbit, a reduction in action of adhesion molecules, and a depletion in dendritic cells. So all of this led to a reduction in cellular rejection and also a reduction in antibody-mediated response as well. This drug is not FDA approved for induction. It's been available in the US for quite a long time, but the most common regimens in the US is a 1.5 milligram per kilogram dose given for 3 to 5 days. There are some centers that will give a big dose up front, 3 to 4.5 milligrams per kilogram, and may follow that up with another dose or two. But generally, most centers that use thymoglobulin induction are trying to get 4.5 to 6 milligrams per kilogram into their patient within the first week or so following the transplant. Ideally, with this drug, the first dose is given prior to reperfusion because it's been shown to reduce graft reperfusion injury. From a drug interaction perspective, there's none. From a safety profile, there's not a lot, but some significant. I'd say about 50% of my patients develop myelosuppression within the first 30 days. and we generally point our finger at thymoglobulin. You get a small percentage of folks that develop a cytokine release syndrome when you deplete a large number of T cells. Oftentimes you can see myalgias, hypotension, tachycardia, or fever. Generally nothing more significant than this. I'd say likely once a year we'll send a patient to the SICU because of this type of response. And rarely you can see serum sickness, which occurs generally 7 to 14 days following the administration of the last dose of thymoglobulin, and generally presents with large joint stiffness, where the patients have difficulty moving their elbows, their knees, sometimes their neck and their jaw. And that occurs in less than 1% of patients. Alemtuzumab is an anti-CD52 humanized monoclonal antibody, and it's currently used for B-cell chronic lymphocytic leukemia, and received about 9 to 12 months ago an FDA label for multiple sclerosis. CD52 is on most cell B and T cells, as well as a few other immune-related cells, so it made a good instance to use this drug within transplant based off of its mechanism. And you get a similar mechanism that you get from thymoglobulin, that you get an antibody binding it to its receptor, recruiting human complement, resulting in T cell lysis. The most important thing that we see with alemtuzumab is just the degree of immunosuppression you get from this. Most folks will argue that you see depletion of your T cells for up to or exceeding 12 months. The first patient that we gave alemtuzumab to, we actually monitored CD4 counts, and this patient didn't have a CD4 count above 200 until about 31 months following the administration of a single dose of alemtuzumab. So it's an incredibly potent immunosuppressant. Some folks you're seeing across the country that use this for induction are using it in regimens where they're using significantly lower maintenance immunosuppression, maybe starting with mycophenolate 500 milligrams twice a day, or instead of shooting for a TAC level of 10 or shooting for a TAC level of 4 early on after transplant. So they're taking this significant induction agent and allowing it to really lessen their maintenance immunosuppression. Again, this is not FDA approved in transplant, and the clinical studies have now focused on a single IV or subcutaneous dose at the time of transplant. No drug-drug interactions, some adverse events, myelosuppression, which can really occur up to and beyond 12 months following its administration. There are some infusion-related reactions, which is why subcutaneous administration has taken quite a foothold. One of the things that is starting to be reported now is late antibody responses in the kidney transplant population. 12 to 24 months after administration, they're starting to hear rumblings that there's higher amounts of antibody response or antibody-mediated rejection in patients that are receiving this for induction. Whether it's this drug specifically or the fact that these centers are using lower maintenance immunosuppression, in particular mycophenolate, it hasn't quite been delineated yet, but that's the big rumbling we're starting to hear with alemtuzumab. I realize this is a busy slide, and I'll try to summarize it quickly. There was a study up at the top that compared the rabbit to the horse. You certainly saw me not talk about the horse ATG, and that's because at 1, 5, and 10 years, the rabbit or thymoglobulin had better biopsy-proven rejection rates as well as improved patient and allograft survival. So no one in kidney transplant uses, or I shouldn't say no one, it's rarely reported that folks in kidney transplant use the horse ATG. In the middle of the 2000s, there was a study that came out from Dan Brennan at WashU looking at Basiliximab versus rabbit ATG in high-risk deceased donor transplants. And this study used a composite endpoint of biopsy-proven acute rejection, delayed graft function, patient and allograft survival, and it showed equivalence. And when they looked at safety, there were higher amounts of infections in the ATG population. So this study was powered to say these two drugs are equivalent, but there's more infections in Thymoglobulin-treated patients. The way everyone read it was they looked at the single endpoints and saw that there was about double the acute rejection rate in Basiliximab-treated patients. So even though the composite endpoint was the same, the study wasn't powered to detect a difference in singular endpoints, everyone read this that Thymoglobulin causes less rejection. And they went back to that old HUMAR data and said, all right, I'm going to get better long-term survival with Thymoglobulin, even though this study didn't show us that. The other interesting thing was that despite the fact that Thymoglobulin is depletional, there was less cytomegalovirus compared to Basiliximab, which no one could explain, and we haven't seen since in subsequent studies. So when this study should have said the two drugs are equivalent, Basiliximab caused less infections, most folks read this study as Thymoglobulin causes less rejection and less CMV, so let's use it. And what you saw was a huge proliferation in Thymoglobulin use across the US, where it's now the #1 induction agent used in the US. And the final study had two different arms, Alemtuzumab versus Basiliximab in low-risk patients, and then Alemtuzumab versus Thymoglobulin in high-risk patients. In the low-risk patients, at 6, 12, and 36 months, Alemtuzumab had improved biopsy-proven acute rejection. That was statistically significant, but there were lower serious infectious complications with Basiliximab. I don't think that this made much of a dent, especially in the low-risk population, as it's a significant amount of immunosuppression to give folks that you consider to be low risk. Now, where we saw this study make hay was in the comparison versus ATG in the high-risk population, basically showing equivalency. There were similar rates of serious complications, even though overall more infection with the rabbit ATG. And what you saw from this was then an uptick in Alemtuzumab use, and I think a lot of that was on the financial end, and we'll get into that in a second. So in summary, all of our agents listed here are used for induction. There's been certainly reports of Basiliximab use for maintenance immunosuppression. I don't think you're seeing it much now with the advent of belatacept, but certainly in the early 2000s, we would keep folks on Basiliximab infusions once every 6 weeks or so as a maintenance therapy. Now, I'm a pharmacist, but I work for the Department of Transplant Surgery, so I'm not the pharmacist on round saying, hey, you can't use that because that's really expensive. But I do like to remind folks, especially when we're working on a DRG, just how much money we're using when we give these agents. So Basiliximab is about $3,000 a dose. So you're looking at about $6,000 to induce a patient with Basiliximab. Rabbit ATG, if you have a 70-kilogram patient, the elusive unicorn, normal weighted patient, again is about $3,000 a dose. So if you're using it like us, you're looking at about $12,000 for induction. Alemtuzumab is free, and it continues to be free. How long it will continue to be free is a different story. But when the manufacturer was studying the drug for MS, they actually voluntarily pulled the drug off the market, both for its oncology purpose, but also for transplant. And if I want to use this, I call up Sanofi, register my patient, and they'll send me a vial for nothing. And it continues to be that way. But now that they've finally gotten the MS indication, I don't know how much longer that will last. But this had a significant implication in the US. If you had the difference between spending $12,000 and spending $0, and the studies show that ATG and Campath provide similar efficacy, if you're strapped for cash, if that's important to your institution, you're going to start using Alemtuzumab, and that's just exactly what we've seen. Now, once they start charging for it again, how that impacts what we're seeing across the US, I think that remains to be seen. In the US, most centers are giving depletional therapy. The majority still remains Thymoglobulin, although Campath has come up significantly in the past 5 or 6 years. There are still more centers that give an IL-2 receptor antagonist than give nothing, but about 15% of U.S. transplant centers report giving no induction therapy, specifically focusing on the lowest risk populations. And now our maintenance immunosuppressants, our calcineurin inhibitors, cyclosporin and TAC, our T-cell proliferation inhibitors, azathioprine, and our 2 mycophenolic acid preparations. We have our targeted rapamycin inhibitors, Sirolimus and Everolimus, our co-stimulation blockade with belatacept, and our corticosteroids. So real simple, how to combine or create an immunosuppressive regimen? Well, you take a drug from your first bucket, focusing on a calcineurin inhibitor, an mTOR, or a co-stimulation blocking agent. Then you draw one from the next bucket with the caveat that if you chose an mTOR first, you're not going to now choose an mTOR again, and focusing on either mTOR or anti-proliferative, and then corticosteroids. There's only 2 or 3 centers that are doing complete steroid avoidance. Most centers that do rapid steroid withdrawal or consider themselves a steroid withdrawal center will still give corticosteroids. We give corticosteroids in all of our patients, but we withdraw about 70% completely from the steroids within 1 to 3 weeks. So we can't get away, given our induction agent, with no corticosteroids. And there's only, as I mentioned, 1 or 2 centers in the US that in their lowest risk patients will do complete steroid avoidance. So remember MG and AP, what would you give for maintenance for each of these patients? Well, I had mentioned to you earlier, does cookie cutter work? It works for us. We're a TAC MPA steroids center. Both of these patients I would put on a steroid withdrawal regimen. Both of these patients I'd keep on TAC and MPA. And depending on how things move following the transplant, I would adjust course depending on that. But I wouldn't change my maintenance immunosuppression given these 2 different histories. I just might use a little bit lower in terms of the maintenance in my older recipient. Dr. Ozzie touched on this already in the impact that signal 1 and signal 2 have on the activation of calcineurin phosphatase. This goes into a bit more detail, showing the nuclear factor of activated T cells with its phosphate groups. Calcineurin phosphatase cleaves off those phosphate groups, allows the NFAT molecule to translocate into the nucleus, where it starts the building blocks for interleukin-2 synthesis. So when you have a calcineurin inhibitor on board, cyclosporin binds to an intercellular protein called cycopholin, tacrolimus to the FK binding protein 12. These 2 complexes bind to and inhibit calcineurin phosphatase. So if you inhibit this enzyme, you never dephosphorylate NFAT, it never translocates into the nucleus, and you get a downregulation of IL-2 synthesis. So your calcineurin inhibitors are interleukin-2 synthesis inhibitors. These drugs have been studied head-to-head ad nauseum in greater than 50 clinical trials, and generally what we know is that patient and allograft survival in the 1 to 5 year follow-up of these studies are generally similar. But what we feel is that we have seen TAC causing lower acute rejection rates. And again, based off of that HUMAR data that showed acute rejections bad, you've seen almost a complete withdrawal of cyclosporin and an almost complete dependence on tacrolimus in the US. Part of that has to do with its tolerability. Cyclosporin, as we know, causes a much greater increase in lipid levels and blood pressure. And we know that the #1 killer of our kidney transplant patients is cardiovascular disease. So eliminating cyclosporin has a beneficial impact there. But what we have to take into consideration now is that tacrolimus is associated with a greater incidence of new onset diabetes as well as neurologic toxicities, in particular hand tremors and headaches. And the more you ask your patients, I think you'll also find confusion and memory issues associated with tacrolimus as well. Now, one thing that we've seen if you're able to withdraw corticosteroids, you can actually get the diabetes risk similar to what you've seen with cyclosporin. So if you're able to use a corticosteroid withdrawal regimen with a TAC backbone, I can get that new onset diabetes down to around 5%, and generally in the population who were at risk for diabetes regardless of the transplant. So there's a book dose, but no specific dose. Of course, everyone is using therapeutic drug monitoring to handle these particular medications. There is nothing magical about a trough level. The trough level is just used because it approximates the overall exposure. So for tacrolimus, the C0 or trough level represents about 90% of the AUC. For cyclosporin, it's about 65%. So that's why some centers have begun or have used a C2 or a C3 level, which is a level drawn 2 to 3 hours after the administration of the drug. A C2 or a C3 has about an 85% approximation with the AUC. The problem is with a C2 or a C3 level, you need to draw the level at 2 hours or 3 hours plus or minus 15 minutes. With a trough level, I can draw the level 12 hours plus or minus 2 hours. So if you have a clinical laboratory like ours where a patient could wait 3 minutes or 3 hours, you may be better off using trough level monitoring, which is what we still do in our patients, even still on cyclosporin. Appropriate levels are dependent on institution-specific protocols and what other drugs are you giving. Like I had mentioned, if you give Campath induction, your goal TAC level may now be lower. For us, we're doing a goal level of 10 for the first 6 months, regardless of either ATG or Basiliximab induction. I'm shooting for a level of 8 between month 6 and month 12. I'm shooting for a level of 6 after a year. After about 5 years, I'm shooting for a level of 4, and that's with or without corticosteroids. So that's our particular TAC goals. Both of these substrates interact with everything. There's substrates for the cytochrome P450, 3A4 isozyme, as well as P-glycoprotein. It's one of the reasons why I'm employed. All of these have tons of other side effects besides the ones that we've already mentioned. As we talked about cardiovascular, glucose intolerance, neurotoxicity is a big one with TAC. They're horribly nephrotoxic because of their vasoconstriction on the afferent arterioles. Most of the data shows that both cyclosporin and tacrolimus are equally nephrotoxic. Both have similar rates of malignancy. One of the most graft-threatening adverse events, however, is the cosmetic side effects that we see. Gingival hypertrophy and hirsutism with cyclosporin in about 20% of patients, and alopecia with tacrolimus in about 20% of patients. So if you have a young female who's losing her hair and you tell her, yes, I know exactly what that is, it's tacrolimus, the next time you see her, she's likely not taking tacrolimus or taking half as much, especially when you tell her it's a dose-dependent phenomena. So it's incredibly graft-threatening, more with the younger patients than the older, but can certainly be a significant problem in this population. There are 2 once-daily formulations of tacrolimus, and here is their PK curves. Now, I'll answer this question up front. You can see this is, in red, conventional twice-daily TAC. This is what you see in all of your patients. This is called diurnal variation, in that they don't absorb it as much at night, and that's typical for most medications. So this is typical twice-daily TAC, and this is a once-daily Astograph, and it's a 1-to-1 conversion. There is a lot of data showing that 25 to 30% of patients that are converted on a 1-to-1 milligram per milligram basis, 30% need an increase in their dose. But that's the label for Astograph. This next one is called Envarsus. This is the newest one on the market. One of the most interesting things is that you don't get a peak. Or you get a peak, but it's a blunted peak in comparison to what you see with Astograph. And the beauty of Envarsus is you can actually use less. So the conversion factor is for every 1 milligram of BID TAC, you use 0.8 milligrams of once-a-day Envarsus. Now, as I had mentioned, with this blunted peak, there's now data showing that you get less neurotoxicity from the Envarsus preparation. The biggest problem with Envarsus is it has wallet toxicity. So, you have your patients that are paying for generic tacrolimus, and they've now finally gotten their copay to $5, and you switch them to this, and in some cases we've seen copays as high as $250 or $300. So, depending on how well it's covered. If they were equally priced, I'd put all my patients on once a day of the LCP or Envarsus TAC. The problem is the insurance cost and the cost, out-of-pocket cost to your patients. Where we've really started to make headway with this is in our patients that present with a hand tremor. Or in patients, we've used it a lot in our African American patients who need very large doses to achieve just a small therapeutic level. We've converted them over with good success in getting them on lower doses. But the bioavailability is much better with the LCP or Envarsus once a day TAC, but you have to take that cost impact into effect. Our mycophenolic acid preparations, we have two. They inhibit the enzyme inosine monophosphate dehydrogenase, which is the key enzyme in the de novo pathway of purine synthesis. So these drugs get into all cells. It's just that when you inhibit IMPDH in most cells, they'll turn on the salvage pathway to create purines. T and B cells don't have a salvage pathway. And so it's very specific for T and B cells, unlike azathioprine, which just gets into all cells and does its damage. So it's one of the benefits of mycophenolic acid is that you get a specific T cell and some B cell anti-proliferative effects. Your typical dosing, there is a book dose. Mycophenolate mofetil is a gram BID. The equimolar dose of enteric-coated mycophenolic acid is 720 milligrams BID. So these two provide the same amount of mycophenolic acid. In the US, people generally do not do therapeutic drug monitoring. You see this a lot in Europe, where they'll do a mini AUC requiring 2 to 3 drug levels drawn within about a 2-hour time period. We tend not to subject our patients to this and stick with the book dose. At my institution, if you tolerate 720 milligrams twice daily, you'll stay on it for about a year before we start making dose reductions. There are some drug-drug interactions. You can't give these drugs with divalent or trivalent cations. So if you have your patient on a phosphate binder, like calcium acetate, right after the transplant, it needs to be separated by an hour or two. If you give your patients calcium or magnesium supplements, they can't take them in the same handful. They need to be separated because they'll chelate in the belly. Now, there's an interesting drug interaction between proton pump inhibitors and Cellcept or mycophenolate mofetil, in that proton pump inhibitors decrease MMF absorption by about 25%. We don't know the clinical significance of this drug interaction. You would think that it would lead to more immunologic problems. However, that's never been proven. That interaction does not exist with the enteric-coated version of mycophenolic acid or Myfortic. From an adverse event perspective, incredibly well-tolerated drugs. They cause some myelosuppression. The biggest problem we see is that they cause both an upper and lower GI adverse event. The enteric-coated version causes the same number of GI adverse events as the non-enteric-coated version because it's a systemic side effect. And so you see similar adverse events in both, and you see this in about 20 to 30% of your patients. The first step that we do is we'll space out the dose. So we use the enteric-coated version. Instead of giving 720 BID, we'll give 360 QID. If that doesn't help, then we'll make a small dose reduction and give 360 TID. We'll make dose reductions until we get down to about 360 BID. If you have to drop below that, it's almost better to convert to azathioprine. At that point, mycophenolate loses its effectiveness over azathioprine, and you're almost better giving an azathioprine preparation. One of the most significant things with this is there's a REMS program. Risk evaluation and mitigation strategies implemented by the FDA. So everyone in this room that prescribes mycophenolate needs to be registered on the REMS website in order to continue to prescribe this particular medication. This has been in effect for about 3 years now. The FDA doesn't follow up on it, but you're supposed to be warning any patient that you newly start on this, females of childbearing age, the teratogenic impact of mycophenolate. Azathioprine, the first drug ever used clinically in immunosuppression, is a prodrug for 6-mercaptopurine. It incorporates itself into DNA where it inhibits purine synthesis and prevents formation of RNA. It gets into all rapidly replicating cells. The book dose is 2 to 5 milligrams per kilogram per day. No one tolerates that, especially with modern immunosuppression with attack, backbone, and induction therapy. And most folks settle out in the 1 to 3 milligram per kilogram per day range. There are only 2 drug interactions with this, but they're probably the most severe drug interactions I've ever seen, and that's with your xanthine oxidase inhibitors. Xanthine oxidase is the enzyme that metabolizes 6-mercaptopurine into its inactive constituents, and if you give a xanthine oxidase inhibitor, you're likely to see bone marrow obliteration in about 3 to 5 days. Your side effect profile, you have a large amount of myelosuppression. Other than that, it tends to be a relatively well-tolerated medicine, especially from a GI perspective. There's been rare reports of pancreatitis. Our mTOR inhibitors, mTOR, Dr. Ozzie had mentioned, sits beneath the IL-2 receptor, and there are a number of different pathways that go through. Everolimus and Sirolimus bind to the same binding protein that tacrolimus does. There's no drug interaction because of that. And it binds to and inhibits the mammalian target of rapamycin. So no matter how much IL-2 hits the IL-2 receptor, the T cells never go into cell division. It's such a fantastic anti-proliferative. Not only does it impact T and B cells, but it also affects smooth muscle and endothelial cells, to the point where there's black box warnings regarding using this de novo in transplant patients because of the potential for a reduction in wound healing or healing of the anastomosis. Everolimus is indicated for de novo use. Sirolimus is not. But generally, it's something we haven't used de novo, and it's something that if we have a patient on an mTOR and they come in for an elective surgical procedure, we'll actually take them off the mTOR, put them back on a calcineurin inhibitor until they've recovered from their surgical procedure, and then put them back on an mTOR. So it makes life a little bit difficult from that perspective. One of the true benefits of mTOR is their clinical impact as anti-cancer agents. They're both FDA approved for the treatment of renal cell carcinoma. They appear to be good and efficacious for hepatocellular carcinoma, basal and squamous cell carcinoma as well. And so it's certainly a group of agents you can use in patients that had a pre-formed malignancy prior to transplant, or anyone that develops one of these types of de novo malignancies following the transplant. And that's generally how we've been using it at the Brigham. There is therapeutic drug monitoring, depending on what your level is and when you use these agents. We generally say our levels range between 3 and 8, depending on how far the patient is post-transplant. Most of our patients wind up on a Sirolimus dose of 1 to 2 milligrams per day. The book dose of Everolimus is 0.75 twice a day. I think the lowest dose we've ever gotten away with to achieve a level of around 5 or 6 has been about 1.5 to 2.25 milligrams twice a day. So we have to use significantly higher because we don't use it with calcineurin inhibitors, which is how the registry trials evaluated Everolimus. Tons of drug interactions, tons of side effects. So just as many side effects as your calcineurin inhibitors, and some that are pretty interesting, not only, as I mentioned, the decreased wound healing, there's also a significant amount of aseptic interstitial pneumonitis, where your patient looks just like they have pneumonia, but is completely aseptic, and you stop the drug and it gets better. One of the more interesting things is it's non-nephrotoxic. So a lot of centers have traditionally used mTORs to focus on eliminating the calcineurin inhibitor long-term. If you plan on doing that, you need to make sure that you convert your patients early. So you can't wait until the patient has poor renal function and then convert, because things get worse. So the general recommendation is, if you're going to use an mTOR to prevent long-term nephrotoxicity of calcineurin inhibitors, Do it before the creatinine gets above 2 and before a patient has more than 500 milligrams of proteinuria per 24 hours, or things tend to get worse. And then belatacept. Belatacept's a fusion protein that acts as a co-stimulation blocking agent, and it induces T-cell energy. And this is our newest agent. Our dosing, if you use it de novo, there's a high dose around the time of transplant followed by a smaller maintenance phase dose, and this is IV only. And the more interesting piece is you base it on actual body weight, and you don't change the dose unless your patient gains or loses more than 10% of their body weight. So even if their weight fluctuates up and down, if it's less than 10%, you leave the dose alone. But your patients need to come in for maintenance therapy every 28 days, plus or minus 3 days, to get an infusion. Side effects, we have a whole bunch listed. It's an incredibly well-tolerated medicine. The problem is you have to be willing to deal with a little bit more cellular rejection, about double in the clinical trials compared to cyclosporin. And then finally, our steroids. There's a lot of nonsense on this board. The fact is we truly don't know how corticosteroids work. We think that if you give high doses, greater than 100 milligrams of prednisone equivalents, that you actually kill T cells. So when you're treating acute cellular rejection or giving your first dose of steroids, we give 500 milligrams in the OR at the time of transplant. We think that's depleting T cells. A maintenance therapy of 5 to 20 milligrams has a general inhibitor of the cytokine response. You see doses vary widely from one group to the next, and there are some drug-drug interactions, and of course you guys are all well aware of the metabolic adverse events of prednisone. The most interesting thing as a pharmacist, 5 milligrams of prednisone, if I had to pay cash at a pharmacy, would cost me $1.20. For a month's supply. Yet to manage the adverse events is about $8,000 a year. So these are significantly expensive medications to use, despite the fact that when your patient goes to pick them up at the pharmacy, they're the cheapest medicine you're going to have them on. When we look at national numbers, most everyone is using tacrolimus. About 90+% of U.S. transplant centers use a TAC-based regimen. I can't imagine why folks decide cyclosporin as a better agent, but there are still some centers using it. mTOR's nationally very little use, about 5 to 10% over the past 10 or 15 years. Now the use is about 3 to 4% nationally. Antimetabolites, mycophenolate is by far the most commonly used immunosuppressant in the U.S., and you're seeing about 30% of U.S. transplant centers are early steroid withdrawal centers, trying to take the majority of their patients off corticosteroids. This is real quick with MG. MG had a nadir creatinine of 1.9. Remember, he got a living donor transplant from his mom. Biopsy showed severe arterial sclerosis that may explain why his kidney function never plateaued at a lower goal. We had TAC running 6 to 8 before we did the biopsy, now 4 to 6 since, on full dose mycophenolate and no steroids. Now's the time where you're starting to run into issues. Is that vasoconstriction from TAC in a kidney that has arterial sclerosis causing significant problems? This was a patient we actually just are in the process now of converting over to belatacept. And this was a patient where we felt getting off of a calcineurin inhibitor would provide some benefit, and we've erred on the side of getting folks off by using belatacept versus an mTOR inhibitor. And I swear to God, guys, I'm almost done. A few more slides. Cellular rejection, you need to deplete T cells. So you can deplete with pulse dose corticosteroids, 250 to 1,000. In kidney transplant, doses above 500 tend not to be more efficacious than 500 milligrams. So generally, most folks don't give higher than a 500 milligram bolus, but generally give for 3 consecutive days as a T cell depleting agent. If that doesn't work or you have a severe enough cellular rejection, you can use Thymoglobulin. And this is where it has its indication of 1.5 mg per kg, generally given for at least 4 up to 14 days. If that doesn't work, you could try Alemtuzumab, especially if you have a patient that you don't think will get transplanted again. Generally for us, we'll stop after Thymoglobulin if that doesn't work. And then finally, my last 2 slides, antibody-mediated rejection. It would be great to have a whole 45-minute discussion about the pharmacology of these particular agents, just because these are agents that are not traditionally used in transplant, but basically borrowed from other disciplines, mostly oncology, because they work on the humoral side of things. So our quick summary, looking at IVIG, rituximab, bortezomib, and eculizumab. IVIG neutralizes circulating autoantibodies and induces a downregulation of antibody production. Dr. Azid mentioned rituximab works on memory B cells. Bortezomib is a proteasome inhibitor that induces cell cycle arrest and apoptosis of plasma cells. There are 2 other proteasome inhibitors. One's called carfilzomib, and now there's an oral proteasome inhibitor called Indiximab. And my guess is that we're going to see a lot of use of Indiximab, especially as prevention of AMR in our high-risk patients. And then finally, eculizumab is a monoclonal antibody that prevents the cleavage of C5a to C5b and thus prevents the formation of the membrane attack complex. One thing that you'll notice is that these drugs are ridiculously expensive. So a 2 gram per kilogram dose of IVIG will run you about $20,000. A single dose of eculizumab at 1,200 milligrams will run you about $27,000. And so you need to use these drugs judiciously. And when you're trying to present them to your hospital vice president because they want to know why you're spending so much money, and you give them a case report of 6 patients, you cross your fingers and hope that's enough to allow you to spend this much money to treat an antibody-mediated response. And that's truly, it's the Old West with very little literature to show exactly what we should be using in an antibody-mediated case.